You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for August 5th, 2022. This week, hyperkalemia and heart failure, cardiovascular health in America, primary prevention defibrillators in the modern era, and a searing debate about medical meetings. First, the drug patiromer in heart failure. The European Heart Journal has published the DIAMOND trial, which studied the use of the potassium-binding powder called patiromer versus placebo in patients with heart failure and a current history of renin-angiotensin-aldosterone system inhibitor or RAS inhibitor-related hyperkalemia. The idea here is that patiromer, a drug designed to treat the side effects of another drug, the RAS inhibitors, so that patients with heart failure can either take any or higher doses of the RAS inhibitors or MRAs, mineralocorticoid receptor antagonist. The issue in many cases of heart failure is that the MRAs, the ACE inhibitors, the ARNI class of drugs, which are clearly beneficial, can't be given or titrated upwards because they cause high potassium. So enter patiromer, which is a powder you mix with water into a slurry and then take. The drug exchanges potassium in the gut and it lowers potassium levels. But the thing is, it also binds other drugs in the gut, and there's an FDA warning telling patients to wait at least 3 hours between taking patiromer and certain other drugs. I'll think about that for a moment. A typical heart failure patient takes oodles of cardiac meds, bunches of other meds, and now they have to take the time to take patiromer only in certain hours. Now, how would such a patient have a life outside of being a patient? Anyways, okay, let's get to the trial. DIAMOND investigators had the idea that if patiromer allowed for more RAS inhibitor use, that would lead to better outcomes. And they set out to test that reasonable theory by counting up cardiovascular deaths or hospitalizations for cardiovascular reasons. And I bet you wonder how such a trial would have come out. Well, you aren't going to know because they changed the endpoint to something else. Sit down for this. They changed the endpoint to a change in potassium levels from baseline. Insert pause. Lowering potassium levels is what the drug does. They already know this. The drug is labeled for the treatment of hyperkalemia. This would be like doing a study of furosemide and measuring urine output, a study of amlodipine and measuring blood pressure, a study of metoprolol and measuring heart rate. So instead of asking whether the $1,000 per month drug improves hard outcomes, they will tell us it reduces potassium levels. Now, the authors write in a manuscript that the reason for this change in endpoint was slow enrollment, changing hospitalization patterns, lower than expected event rates, and of course the uncertainty of the pandemic. So the sponsor, with the recommendations from the steering committee, changed the study objectives. Now, there are some things to learn from the trial. First, there was a run-in phase. Of course there was. In this run-in phase, patients got either 50 milligrams of spironolactone or eplerenone while taking a RAS inhibitor at 50% of target and patiromer. And 84% of the approximately 1,000 patients, now these are patients who had hyperkalemia, 84% were able to achieve these goals, the goals being greater than 50% of the target dose of RAS inhibitor and 50 milligrams of spironolactone. These patients were then randomized after the run-in phase to either keep taking the patiromer or the placebo. And the results were obvious. Compared with placebo, the change in potassium levels was a negative 0.1 millimoles per liter, which was highly statistically significant. So remember, a drug whose purpose it is to lower potassium, lowered potassium by 0.1. That's like going from a K of 4.8 to 4.7. And secondary endpoints such as the number of patients with hyperkalemia were lower in the patiromer arm, as were the number of patients who had MRA reductions. So the conclusion in the abstract was a classic case of spin. This is just so instructive. Now remember, spin is language designed to detract from the primary endpoint. The authors wrote, quote, concurrent use of patiromer and high-dose MRAs reduced the risk of recurrent hyperkalemia. Well, this is a true statement, but it was a secondary endpoint. The proper spin-free conclusion would be to emphasize the primary endpoint. Use of patiromer reduced the potassium level by 0.1 millimoles per liter versus placebo. That was the primary endpoint. Now, my friend and virtual mentor of sorts, Milton Packer, wrote the editorial, and as always, this man teaches us stuff. He first told us about the Rouse and Emphasis studies, which established the substantial benefit of spironolactone and eplerenone in heart failure. He then wrote that in clinical practice there is a great fear of high potassium, and there is widespread inappropriate use of MRAs, including A, not checking potassium levels, B, not stopping potassium supplements, and C, not reducing the dose of MRAs. By the way, this is all totally true, and it's one of the reasons that make heart failure trials harder to translate to the real world. Because in trials, we have research nurses and pharmacists to help do this. And in the real world, clinicians are overworked, and there are not those fail-safe mechanisms. Packer then goes on to tell us that in the PEARL-HF trial, patients with heart failure with reduced ejection fraction were randomized to patiromer versus placebo to determine if patiromer might enhance the tolerability of spironolactone at 50 milligrams a day. And in that trial, after 4 weeks, the patiromer group was more likely to receive the higher dose of spironolactone, but it was only 91% versus 74%. But here's the thing. Packer had also just told us that in Rouse, the mean dose of spironolactone was only 26 milligrams, and that was enough to deliver huge benefits. So it's clear that he believes there is little need to push higher doses of MRAs. So he then noted the endpoints in Diamond, which are unremarkable, right? Just changes in potassium. But then he pivoted quickly to the fact that 80% of historically hyperkalemic patients did not report a K greater than 5.5 during double-blind follow-up, even in the absence of patiromer, and even though they were getting high doses of MRAs. Now, see, this is also an example that you can do stuff in trials that's harder to do in the real world. Packer then pointed to table S4 in the trial. Patiromer did not enhance the dosing of RAS inhibitors, and the proportion of patients taking comparable doses of MRAs, either 25 milligrams of spironolactone or 50 milligrams of eplerenone, were nearly identical in either the placebo or treatment group. So the most important finding from Diamond, Packer writes, is that MRAs were stopped in 7% of patients in the placebo arm versus 5% in the patiromer arm. The investigators therefore treated greater than 400 previously hyperkalemic patients with patiromer for 6 months to achieve an 11-patient difference. And actually, he points out that that's the NNT to prevent one heart failure hospitalization with MRAs over 3 years. So given the expense of patiromer over 3 years, it is very unlikely to be cost-effective to prevent one heart failure hospitalization. And Packer concludes, by salvaging the Diamond trial, the investigators delivered enlightenment. Specifically, they found that in the vast majority, more than 80% of patients with heart failure and a history of hyperkalemia will not experience recurrent hyperkalemia in the absence of patiromer, even when challenged with doses of MRAs that are likely higher than those needed to reduce mortality. And importantly, he says, the proportion of patients who tolerate MRAs without hyperkalemia and without potassium binders will only increase in the future, since 2 foundational drugs, the ARNIs and the SGLT2 inhibitors, mitigate the risk of hyperkalemia and also have direct benefits on heart failure outcomes. He feels that these are immensely reassuring findings, and that if we truly seek to improve outcomes in clinical practice, we must assuage physicians' exaggerated fears about the dangers of hyperkalemia. Since trial-based MRA dosing strategies currently represent an exceptionally cost-effective and well-tolerated way to slow the progression of heart failure with reduced ejection fraction. Okay, some brief comments. Dr. Packer is right about good doctoring. If we could create this trial-like atmosphere, more patients with heart failure could gain the benefit of MRAs. The trouble is that what is possible in drug-sponsored trials is not as easy to do in practice. MRA use in the real world goes like this. Everyday doctors are faced with two choices. One, the risk of death from hyperkalemia versus the missing out of a potential relative risk reduction in the future. In this situation, many docs choose to just hold the MRAs. What is clear from this trial and from Packer's commentary is that a $1,000 per month drug with drug-drug interactions requiring spacing of multiple drug intake will not change that calculus. Now, had we had a trial that shown a reduction of death or hospitalizations, that would have been a different story. All right, next topic, the future of cardiovascular disease. Jack has published a paper from a Harvard group, first author Reza Mohibi, that attempts to project the number of people with cardiovascular risk factors and heart disease into the coming decades. Now, they use NHANES data, and NHANES is one of those longitudinal health studies that follow people over the years, and it includes diverse communities. The authors then do logistic regression and combine the findings with census reports, and all this is complicated. Healthcare journalist Marlene Busco, in her title of the news story, called the findings staggering. This is an excellent news piece, and I would definitely refer to it. And I would say, indeed, the findings are staggering. The number of people who the authors predict will develop diabetes, hypertension, abnormal lipids, and obesity is going to increase by tens of millions. And same with actual disease. True ischemic heart disease, heart failure, MI, stroke are all going up by millions. Their model predicts that minority populations will fare even worse. Particularly striking was a steep rise in diabetes in Black and Hispanic populations that they predicted. Now, my comments. The TWIC podcast has touched on this topic many times. This study is especially stark because they put absolute numbers to the projections. Now, I have a bunch of talks on the humility of medicine, these PowerPoint talks. I always show some slides of the vital statistics on lifespan over the past 50 years in the U.S. Do you know that despite huge gains in imaging, pharmaceuticals, procedures, cath labs, Watchmans, EP labs, MitraClips, TAVIs, and of course digital health with smartwatches, the average lifespan of all groups in the U.S. is essentially flat, so flat. So the Mandrola theory is that while modern medicine can indeed extend life, this is going to be counterbalanced by the increasing unhealth of the populations we treat. Okay, now to the paper. First comment is they go out to 2060. Now, I don't know about you, but given the current state of affairs, it's hard to wrap my head around 2060. Will there even be a 2060? And as for the accuracy of their predictions, all one needs to do is go out of the wealthy parts of cities. Visit Middle America, or come see me here in Kentucky and open your eyes. I mean, thinking in terms of the physical exam, right? The general appearance of American health is scary bad. In my clinic, in the grocery store, kids' sports events, especially in airports, you see that obesity and having limited mobility has become normalized. It's truly shocking. And you add to these observations the many papers I have covered previously on the atrocious state of kids' cardiometabolic health. So I think the authors of this paper may be underestimating the coming calamity in non-communicable disease. Now, as for solutions, here's where I differ from the narrative in many parts of the medical establishment. I feel that doctors and healthcare per se have very little effect on this. Yes, we can of course stop normalizing ill health by ignoring someone's obesity or sedentary lifestyle. For instance, I frequently see patients with AFib who are obese, and when I discuss the relationship of weight and atrial fib, they look surprised, as no clinician has discussed this with them. I've had patients say, my doctor said I have great numbers. But still, doctors treat individuals. The problem that the Harvard group and others have identified is way, way upstream from individuals. I've also previously covered the extremely strong evidence base that shows that more easily available health care does not improve outcomes on averages. Many studies show this. The cardiovascular health problem we have is cultural and societal and can only come from changing norms. Now, I don't have an answer for that, but I'm sure it is not more medical centers that give out more pills and do more stents that's the answer. It's much broader than that. Okay, some examples. I ride my bike to work. I live in a city of about 1 million people. I see 0 people riding or walking to work. 0. One reason is that there's no infrastructure. It's not really safe, and there are a few places to shower at work. Okay, another example of norms. I always ask patients what they do for exercise. And some tell me that they go to the gym 3 times per week. And I'm like, well, what about the other 4 days? What do you do? Okay, another example. When I volunteer in my colleague's clinic for disadvantaged people, I realize how little these people need a cardiac specialist. What most of the people in that clinic need is far more basic than what a cardiologist can provide. And let me close with an even more sober comment. I'm pretty sure that no one knows the best way to change these norms. America is not Denmark. We are a sprawling, diverse country born of rebelliousness, and that makes it hard for any one policy to work. There is a great debate as to the best policy to improve population health. I have no idea which one will be best, but I can say this. The most recent approaches don't seem to be working. It's like burning in the wrong area of the heart and not terminating the tachycardia. When that happens, it might be worth considering different approaches. Okay, third topic, primary prevention ICDs in the modern era. The journal Jackie P., of which I'm a social media editor along with Janet Hahn, has published a provocative paper from the University of Pittsburgh group, first author Mehak Dahandi. This group wanted to assess the impact of the number of guideline-directed medications prescribed for heart failure on all-cause mortality in patients who get an ICD, and actually used their own database of patients who had an ICD in their center from 2010 to 2021. It was nearly 6,400 patients. Most of these were primary prevention ICDs. Their primary endpoint was the rate of all-cause death at 2 years after the implant in those who had either a primary prevention or CRT device. They then correlated 2-year mortality with the number of guideline-directed medication classes. Now there's 4 classes, either 1, 2, 3, or 4 drugs. These are beta blockers, RAS inhibitors, MRAs, and SGLT2 inhibitors. And they found that after adjusting for age, sex, ejection fraction, BMI, comorbidity score, and the type of cardiomyopathy, and the year of device implantation, each additional class of medication conferred a reduction in the risk of death by about 36%. And you got to picture the Kaplan-Meier curves that look increasingly less steep with the number of meds. They then take these associations and make 2 conclusions. First, they say, the initiation of a maximum number of tolerated guideline-directed medications should be the goal for all patients with heart failure and reduced ejection fraction. And a second conclusion, they say that in the setting of robust guideline-directed medical therapy, the risk versus benefit of the primary prevention ICD warrants re-examination in future studies. Okay, let me make 2 sides of the critiques. First, a small critique of the study. This is an association study. Sure, patients who took the 4 classes of meds did better, and we have strong data that these drugs provide incremental benefit over placebo. But I also think the ability to take these 4 meds may also be a marker for a healthier patient, and that is why they may have had better survival. I assume the University of Pittsburgh gives pretty high-level care, and if a person with heart failure could be on 3 or 4 classes of drugs, the doctors would have prescribed them. So it's possible that their finding is at least partially an association rather than all causal. But now to the other side. I mostly agree with them that sudden death rates in heart failure are dropping. For instance, it's not just my opinion. In 2017, a group of heart failure trialists published in New England Journal of Medicine a very important but not very highly cited paper showing that there has been a steep decline in sudden death over the years in heart failure trials. I'm going to link to this paper, and it's really worth a look. Here's a quote from the paper. There's been a 44% decline in the rate of sudden death across the trials, and the cumulative incidence of sudden death at 90 days after randomization was 2.4% in the earliest trial and 1% in the most recent trial. So think about that. If the sudden death rate is hovering around 1%, how much benefit can you get from an ICD? Now, the University of Pittsburgh authors therefore confirm the heart failure trialist observation. And this is everything, isn't it? It's everything because ICDs are dumb. They only prevent one kind of death, from arrhythmia. Now, that was a huge deal 20 to 30 years ago when sudden death represented such a huge proportion of total death. But now, with better medical therapy and also temporal trends and better treatment of MIs, for instance, the proportion of sudden death is greatly decreased. Yet the risks of the ICD remain pretty stable. So the authors are correct. If we did another scud heft or made it 2, there's a very good chance that there would be little benefit on average to the ICD over medical therapy. I mean, look no further than the Danish trial. Non-ischemic cardiomyopathy, bad EF, 6-year follow-up, ICD, no benefit over medical therapy. It boggles my mind how the EP establishment has essentially ignored the null finding of that extremely well-done trial. Upton Sinclair comes to mind. I'd love to see another ICD trial, though I don't think it will happen because the therapeutic fashion is still pretty strong. Finally, a brief comment with a fun topic on medical meetings and digital posters. When we started going back to medical meetings this year, the poster sessions had changed. Gone were these rows of paper posters attended by impossibly young and earnest people anxiously awaiting any questions. Now we had these little pods of people listening to one person discuss their poster on a digital screen, and the listeners had to have tuned their headphones to hear the speaker. And the digital screen was super small, and it was detached, sterile, almost a dystopian-looking thing. Well, via social media, a number of influencers spoke out that we needed to bring back, gulp, the paper posters. The Heart.org Medscape Cardiology has great coverage of this debate, this poster controversy. And I agree totally, and I told Rod Tung on a Heart Rhythm TV interview. The paper posters may be a pain for someone to travel with. They may not be as green as a digital poster, but they were better for 2 reasons. One, they allow a casual perusal. You could stroll lines of posters, and there would always be a few that sparks an interest, even changes a practice. I first learned about micropuncture and ultrasound access from a poster. And perusal's just not the same digitally. It's just not. Second, and more importantly, paper posters led to human-human interactions, often with these big groups. I mean, my friendship with Piotr Futima in Poland stems from a meeting at a poster. So connections, human connections, are highly underrated. So no, paper posters, they're not going to solve the crisis in cardiovascular health. But it was one of the biggest draws of actually attending a medical meeting in person. Remember, my friends, sometimes what is new is not better than what is old. And so that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating. Even 1 or 2 sentences go a long way to help others finding us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.